Health savings account, the money that is being put in on behalf. I'm just curious, as far as IRS perceives that, is that considered taxable income for them because they didn't do anything to contribute that in, or have y'all looked at that to give any relief on that?
It's a good question. I don't know that we have actually looked at it.
Let me ask for clarification, Senator. So, Representative, are you saying does the contribution made to the independence account impact them from an income perspective as far as the IRS treatment?
Yes, whether that be, because part of what I heard was that we as a government are going to be putting money in these accounts, if I understood right, and I want to make sure whether or not that's been looked at as far as, is that going to be treated as taxable income to them or adversely affect them? Say, because I hear a lot of cases where individuals lose their benefits because they're $20 over the limit. So have you researched that, or could you get something done on that and come back to us, give us a comfort level on that issue?
We will certainly come back and provide all the details on that. At this point in time, it's our understanding it is not countable income for purposes of that, but let us get all of the detail about that and provide that for your assurances.
Okay, thank you. And then second question, if I may. What I heard said a while ago, I want to make sure I heard right, was that if an individual presents themselves to the doctor and they have not made their contribution to their HSA account, they've not done their part, that at that point, that card can be deactivated. So they go to the doctor, it's deactivated. Is it my interpretation at that point the doctor becomes the bill collector if the doctor provides services to that patient, knowing that that card has been deactivated? And can you speak on that as far as the position that puts the doctor's office in having to collect?
That's a great clarifying question. First, I want to clarify that only applies to those making over 100% of poverty.
And what's the number? Could you give me the number of how many we're talking about over 100?
34,000.
34,000, right?
Okay.
And what is deactivated on the card is payment of their cost sharing, not payment of the service. The service will continue to be paid as a Medicaid service. So as Dr. Thompson responded to the earlier question from Representative Ferguson, what the provider then is placed in the position of is saying, okay, your copay is not covered under this. Your copay, I'm going to make up numbers here, is $20 today. You need to pay that out of pocket. If they choose not to do that, the provider needs to decide, am I actually going to see this person today? They will continue to bill for the service as a Medicaid service, but they will be responsible to collect the $20 is the understanding here, and it will show on the statement.
Okay.
My only qualification is it's not a Medicaid paid service, it's a qualified health plan paid service.
I'm sorry, I forget where I am. Qualified health plan service. Thank you.
Okay, then Dr. Thompson, based on the answer to her question, if I'm a doctor, how is that going to impact me if I'm part of a medical home umbrella and I'm expected to provide service to this patient who is not able to pay their fee? And how is that adversely going to affect me as far as me being able to get back because this patient isn't doing their part to participate in their health program? And as a doctor, am I going to be adversely affected at the end of the day as far as the money that I get back because I'm providing holistic care to this patient?
So every one of our incentives that we're putting in place, whether it's our payment improvement incentives or whether it's these structures on the cost sharing and the window into how the program works through independence accounts, we're trying to reinforce more accountability both on the provider side and on the patient side. So we're trying to move the whole system to a different place. Above 100% in that window, just like above 138% for other insurance, the individual has some responsibility for paying a portion of their service in a copayment. That is to help guide utilization. When you don't need to go to the doctor, you choose not to go to the doctor because you're going to have to pay for it. Conversely, when you do go to a doctor and there's a treatment plan, you adhere to the treatment plan so you don't have more visits than you otherwise need. This is part of the shared responsibility. Directly to your question, President Hammond, the providers in our patient-centered medical homes now have an incentive, financial incentive, to engage with their patient and teach them how to best utilize the healthcare system. They've never had that incentive before. They've had an incentive to see them more times and to not keep up with them where they go. And as a primary care physician, that's not our ethos, but the incentives haven't been there for us to invest. The incentives are now there to invest, to help teach our patient where and how to go, how to use their benefit, how to minimize their financial risk, and therefore the system's financial risk.
So are you saying the doctor ought to make up the difference because it's part of their responsibility to educate these people and make sure they get the care?
No, it's the individual's responsibility to pay for it.
Okay, all right, thank you, Mr. Chairman.